Yes, we are in.
Can you hear me? I guess I was talking to myself.
Yeah, you were.
Okay,
Good.
I'm
Yeah.
gonna make you guys add, hold on, really quick at the top, right?
What was that?
I'm trying to make you guys admin.
Just at the top, the three dots.
Hmm.
Just
Oh,
say,
here we go, make co-host, got it. Okay.
hi everyone. Thank you so much for your patience. Thank you for coming out tonight. We had some technical difficulties getting logged in on this Monday. So thank you so much for all your patience. And we're about to get started, okay?
All righty. Just completing. Okay. You want to press record or is it already recording? Yeah?
It's already recording. You're good.
Okay. All righty. Thank you. Good evening, everyone. I would like to welcome you to another webinar that we are hosting via Women in Emergency Medicine with tonight's topic being how to transition from MS4 to PGY-1. I am your host, Renata. I am a fourth-year medical student at Ross University. I would like to congratulate all of our newly matched rising PGY-1s, including my co-hosts. You can go ahead and introduce yourself.
Hello, everyone. I am Kristen. I am an MS4 as well, and I will be the co-host this evening. So, guys, we made it to the end. Congratulations to everybody. We're excited. This is our very last webinar of the series. You've had a great season. We have two panelists joining us this evening. If they would like to introduce themselves right now before we get started with questions.
Hey, I'm Delroy Daly. I am a first year resident at Broward Health. I went to AUC. So if you went to AUC, well, this is an IMG webinar, so it's probably a few AUC people here, but all the IMGs definitely stand up. And yeah, I'm glad to be here today.
Thank you. Is
And Tam, would
Dr.
you like to
D.
introduce yourself?
Oh, sorry, my bad. It's me.
wonderful.
Hi, I'm Tamara. I am an intern at Advent Health. About to start second year. Oh my gosh. Went to Ross. So all my Rossies out there.
Yay. Thank you guys so much for joining us. We're going to get started with questions. Guys, if you have any questions along the way, pop them in the chat. We're going to keep an eye on the chat box and ask questions as we go. So let's kick it off. It's the night before residency. We're excited. We're getting ready for the next day. Our alarm goes off in the morning. What do we need to bring on our very first day of residency?
Positive attitude.
Yes.
Um, yeah, for sure. Positive attitude. I think that this is all EM, or is there multiple? Okay.
No, this is all EM, yes.
All EM.
So yeah, definitely positive attitude. Be ready to have a few supplies on you, like stethoscope. Bring some shears. In EM at least in my program, we have like an intro to EM block first, so we don't really jump into it that first month. So I guess it's program specific, but definitely bring your supplies. And yeah, just be bushy-tailed and wide-eyed. You know, it's going to be a lot to learn, of course. I think that's something you guys already know, right? Um, Yeah, that's pretty much it. I don't know. And tomorrow, nice to meet you. I would definitely say maybe tomorrow has another idea or something, but yeah.
I have to say, I mean, a stethoscope, I don't know, every program is different, every hospital is different. There are many times that I had lost my stethoscope or it was out of commission as the plastic belt cover piece had been lost as well. So we have like disposable stethoscopes, they suck. But they're there. I would say, I mean, I don't know if it will be helpful to like kind of how the next, I guess, the month of June looks like into starting residency too. Like, because it's not just like July 1st, like welcome, and you have a couple weeks before July 1st where you do your EMR training classes, you do all your HR stuff, you do your employee health, whatever thingy, like so you'll get to know your intern class, your co-interns, you'll meet faculty. My program, we had like a graduation dinner a week before we started. So you start to get to know everybody and get all the faculty and attendings and your other co-residents way before you start July 1st. My program also had like an immersion block, which was super helpful. It was like 14 shifts or 15 shifts that first month. It's just you're just an extra in the department. So as far as like what to bring your first day, just whatever your your scrubs color, whatever the policy is on scrubs, a stethoscope, shears. I tried a fanny pack for a little bit because I was annoyed with the carts always, it's ER, like we just go through stuff all the time. So every time I look for a tongue depressor or something, it's not there. So I had like a little fanny pack of just like goodies that I stole from the supply closet, but then I stopped doing that. So honestly, it's just be you won't there's zero expectations for you to like go gung ho your first day. So just kind of like I said, positive attitude, just be a sponge the first couple weeks and you'll do well.
Awesome. Thank you. So fanny pack and a positive attitude, and you're good to go on your first day. Thank
I
you
feel
for
like
that.
stethoscope is definitely a must have
Of course.
though.
Okay. Awesome. Awesome. So the next question that we have, what are the big differences or the major roles as far as transitioning from a medical student? So what are the differences as far as a medical student and now you're a PGY-1? Like what is it that's going to be expected of you? And how much autonomy do you have as a first year resident?
Low expectations. So let's start there, right? There's a and it's expected to have a um this rite of passage, right, before you're this, quote unquote, full on doctor. I the transition is just you keeping a student mindset, knowing that you're a doctor, okay? Um, your job is to become proficient first, and anything that is above the scope of like, I don't know what to do next, you pause and then you look it up and then you ask for direction, right? Or without you don't ask just an open-ended direction. You said, hey, I think this is something I want to do based off these findings and these signs. What you this is something and you tell the reason behind it and you say, do you agree? Do you disagree? And and then take your attendings or your senior's recommendation from there. That's what you should only do. Slow and steady is going to win the race in the beginning, and you get graduated responsibility. There is the program is going to quickly know who kind of is on it, kind of needs a little bit of help, or who is really struggling, and you will know that as well. So don't think, and that was my mistake. I thought that, because wherever your ego is personally, you think that, I can do it, I can do it, I can do it. And, which is great, but, patients' lives are also at stake too. So you just want to take your time and, one foot in front of the other.
I do get this question. I do get it a lot. Like, what's the hardest part of going from a med student to resident. And honestly, it really wasn't a hard transition. For me, I really don't feel like there was like a separate transition. I think the biggest thing as far as the logistics is that like as a med student, they say like, oh, go see this patient and room, whatever. And then you present the patient, and then sometimes you follow up, sometimes, you go see another patient or whatever. But now as an intern, you sign up for a patient, you're expected to see them start to finish, dispo them, like all the whole nine, call the consultants or whatever if you want to admit. And then like you don't realize how time consuming, like how inefficient you are. And then I think that's the biggest thing of intern year is obviously like knowledge will come first year, second year, third year. And first couple months, I mean, at least my program, they were so nice and nobody was judgmental at all. Oh, the knowledge got like they know that you're so nervous and things that normally know or whatever. They understand that like you're an intern, you're not going to be compared to a second year or third year. But it's the whole of like seeing your patients from start to finish. I think that's the biggest transition. After a month or so, I got used to it and it wasn't that big a deal. And I started seeing more and more and picking up more patients. Every program's different, but my program had kind of a set expectation. Okay, by 6 months into your sixth intern year, you're expected to see this many patients per hour. By second year, third year, etc. So don't focus on the numbers, but it's more about trying to push yourself to be more efficient. And then my biggest piece of advice, and I feel like my intern year went super smooth because of this, is, and I will reiterate, I said it before, I'll say it again, a good attitude. Residency sucks. Set the expectation that residency sucks. I mean, there's some places that are better than other, but it doesn't matter what specialty or what program, residency sucks. And if you have that expectation and that you're gonna have to make sacrifices, you're gonna be tired, you're gonna, miss out a lot of events, then it makes things go by so much smoother and with your co-residents and your faculty and attendings.
Got it. So it sounds like we get a very gradual kind of introduction to being a doctor. Now, is there any specific challenges that you face that you feel could have been prevented with any sort of preparation beforehand, whether that be, readings or videos or, anything to brush up on that you feel like, you would like to share with us?
No, enjoy now. The time is it's time to enjoy. It doesn't matter how much or how little, you're all gonna start off the same come July. So enjoy. There's nothing to prepare you before.
Okay.
At least that's my thought. I don't know.
If someone did, let's say they did want to kind of go the extra mile and do a reading or watch a video series, is there anything you guys recommend?
I think that well, like Tintinelli's or Rosen's, right? Whichever your program is based out of, our program is Tintinelli's. So if you want to read ahead, that's great. You don't technically have to, because a lot of the things that you should know, you already should, at least at baseline, like have some sort of grasp in some way, right? You're gonna gradually get better. I would also say that I would your mentality should be probably the best thing that you are focused on right now. You are going in, you're going to mess up. You're going to F some stuff up, right? And then, some attendings are going to be either really hard on you, somewhere in between, or, be very, very understanding. Get the idea of that you're a fourth year and that you're a senior out the window, right? This is a brand new thing. You are a infant in this realm. Okay, there's going to be a lot of hand holding early on, but expectations that you're going to get better, and people will yell at you. People will, maybe not outwardly yell at you, but you will be 100% spoken to in some ways that you don't like. And it is just what it is, so throw your ego to the side. And that would be like mindset over anything right now.
As far as like if you if if it helps make it to look at it this way, that like July 1st is day one, and then whenever you take your board exams at the end of residency is when you really that's when you are supposed to know stuff. So this next month or two of trying to get ahead of the game is not the whole point of residency is to help you get to be board certified. So this time right now, maybe you'll remember a step two detail or things like that, but it's different when it comes to emergency medicine knowledge. So, when you apply it with actually seeing patients and into it, it's a lot easier. So I think there's better ways to utilize the time that you have now because you'll have 3 or 4 years to get there. But flash review always works.
Okay. So a review and probably spend as much time with family as you can because it's
Yes.
probably going to be limited once you start residency, right?
100%. But yeah, Rosh Review, Tintinallies, Roses. There's a lot of EM podcasts out there if you just want to listen to some stuff like while you're doing out and about.
Okay. Sounds good. Awesome. So now the next question, I'm pretty sure a lot of people want to know, because I know people are in the process of getting schedules and they may or may not have gotten it just as yet. So what is like an intern year, your typical schedule? What should that like look like? Like break down the structure of what your first year in residency will look like. Schedule
As
wise.
far as every program differs, whether it's 12-hour shifts, 10-hour shifts, something in between. Um, but pretty much ACGMA has guidelines as far as how many hours and shifts we're supposed to do and stuff like that. So it's not much variation. First year is definitely a lot of off-service stuff, as we're with any other specialty. So for us, we had 13 blocks, 4 weeks per block, and almost half of them were off service rotations. I picked out my schedule that I wasn't on two off service back to back. Like I want to be able to have a break, so I had 2 months of EM, and then every other month was an off service. Which some were ICU. I feel like every ICU rotation, no matter what hospital you're at, is going to be um, very time consuming, very tiring. And then the other easy stuff like ortho, we had ortho as our vacation block pretty much. But so you'll have your freebies and stuff and some off service if they're really chill or something like that. So I feel like you probably maybe not by hours but like by mental load of running a department and stuff like that, I think you do more hours intern year because I think it's like every program is like, oh, you do less shifts per month, per year. But I feel like you work more, at least mentally, second and third years. So
Yeah, so I think it's program specific. I know in our program, um, I think we get 7 EM blocks, and I think the rest are off service. Um, and yeah, I would just say I'm getting a little bit of ICU. I think we get 2 ICUs in the first year, and outside of that, it's just program specific. So your schedule just and depending on how flexible your program is and allowing you to pick your schedule, sounds like uh, tomorrow's program is a little bit more flexible than than our program.
oh
So
no.
yeah, we just give them three months to where we want to possibly have some vacation blocks, and they try to work around our schedule, and then they just create it around that. So yeah, it's program specific. Mhm.
Okay. Now, it seems like you guys have really reiterated this positive attitude, take your time off. But is there anything that we can do as incoming interns to help us set ourselves apart from other people?
I would say I feel like I'm a pretty average student. Like my clinical knowledge is pretty average, or I'm supposed to be where I'm at. But I think what I I don't feel like I want to like, pat myself in the back, but I have not had one problem, got in trouble or anything like that. And I'm telling you, what feel like sets me apart, um, is because, I mean, they always tell me, they're like, Tamara, you don't complain. I was like, well, I mean, I don't have anything to complain about. I mean, residency sucks. I'm not going to complain about it. Um, and I feel like I get along with everybody. There's some times that even with like consultants and, when I place a call out for a doctor specialist, and then they call me screaming at me, and I just bite my tongue, and I just like put on my phone, like whatever, blah 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 blah, let them like yap away. But I don't fight with anybody. I don't really get in arguments. I feel like I try to keep my ego in check. I'm nice. I think that really your nurses are going to help you out, all your ancillary staff, getting really close with them. I think that's what sets you apart more than knowing the cover to cover of Tintinellis. Like that's what's going to set you apart, is just being just friendly with everybody, being a sponge. Um, and that will have you easier time, because you really wanted the first 6 months to put your head down, do your work. Don't be a problematic person, because then if once after 6 months they trust you, they know you, and if there is an issue that you actually have something to complain about that bothers you, they take you that much more seriously. Like for example, our trauma rotate. We are not a trauma hospital, so we go offsite for trauma in Miami, and the place where they put us was awful. And then so they tried to try out another place, and of course I was the guinea pig. I go there, I was like, no, this place is worse and this disgusting. And they came down themselves. They're like, well, if Tamara's complaining, then it's bad. So they came down, they drove them themselves, and we went looking themselves, and they would make sure I proved it before finding us another spot. Like that's how seriously they took my complaint. So I think that's what sets you apart. I know like you want to study and be like the most knowledgeable person, and maybe some other specialties that's true, but in EM it's about all the other stuff. Trust me.
Yeah, I would add that, and I wonder what hospital that was. I would add that initiative is going to be, one thing that helps set you apart, if anything. And before I add to why, not why, but what you can do, I got in trouble. I get in trouble, and it's not because like I like getting in trouble. I'm a person who asks for forgiveness later, right? And sometimes it really like makes you look great, and sometimes it just really is like you just shat the bed, like dang. You know, I was trying to think ahead. So I would say that be confident in your in what you know, right? And also be confident in what you don't know, right? Don't try saving the world yet. Next, when you're on off-service rotations, right, they may or may not onboard you, right? They may say, oh yeah, we gave this person a packet, and that packet had nothing to do to the day-to-day, like it has 0%, right? So finding a senior to say, hey, listen, I need like some quick hitting bullets on how to be good in this rotation. Um, what are some orders? What are some order sets? What are some workup ideas? Like I just got off trauma ICU, and I'm like dead exhausted right now. Just to let you know, I had a 24-hour.
I just came up from trauma too. Oh my God.
Yeah. Like I got home at 10 a.m. at the 24-hour, and it was just like so busy overnight. And so if I'm like a little low energy right now, I was just telling my wife, like, I just feel like sick right now. But anyway, to add, doing that first helps, right? There's going to be somebody coming off of that rotation, and ask that person, how did that rotation go? Or the nuggets and pearls you can get. But alongside with that, there's a couple things I would like tell you guys to do now, and that is like download some apps, right? Like EOLAS, EOLAS for WiEM. And if you haven't used it yet, it's like the EM Wikipedia for when you're on clinic. So you could just put in WikiEM, WIKIEM. Um, get Pedistat, PEDISTAT. That's for all of your pediatric emergency medicine things that whether it's Pediatrics is weight dosaging, so you can put in the patient's weight and what you're trying to treat, and it'll give you options and such based on that. Also, download the I think it's IMRA's antibiotic guide.
I was just gonna show it is, isn't it? It's like $10 a year or something,
Yeah.
right? Or
For
Emra gives you, they have the book. I use the book mostly.
Oh,
I lost my book, so it was I don't know.
yeah, yeah. They give you the book, so you should get like
Uh,
IMRA like package of like different things, right? And use that. So that book should be on you. I can't find mine, so that's why I got to
oh,
just
mine's like, yeah, I think I had an extra one and then it's
yeah,
somewhere, but I use that thing religiously. That I think I use the Emra antibiotic guide more than I use anything. I
yeah.
use it more than I open up my phone. I carry that in
So
my pocket.
literally, those are your things.
Yeah.
Your attending is going to say how to treat blank, right? Oh, another thing. There should be
Oh,
there's some low hanging fruit problems that comes to ED, right? Belly pain, UTIs, STEMIs, chest pain, blah blah blah, right? You should be good at 10 to 20 of these things in terms of like just theoretically, right? Understanding. Now, when it comes to the presenting, it may take you a little time to like gain like, oh, this is actually scape, or this is, versus a STEMI, whatever. But those things you're gonna get pimped on those, and I hate that word, but you're gonna get pimped on, how do you treat this UTI? Well, you should say, well, listen, back pain. What if they have a kidney failure? Well, you can do Keflex, right? You should have the gold standard treatment and one alternative in your back pocket. All right. Like, and if you don't know, that's fine. Always say, hmm, give me a minute to look it up real quick, rather than trying to guess off the top of your head. Good guesses are great. Bad guesses make you look stupider. So, just say I don't know, and I'll look it up right now. But I don't know shouldn't be like your go-to answer anyway. Just say, hey, just give me a moment, doc. I'll tell you in a quick minute.
there's another two more apps. One's called Suture. If you doesn't take long to get good at sutures, but in the beginning to know like, oh, which one should I use? Should I use a 5-row Prolene? Should I use a 4-row nylon? And how long do they need to keep it in? That one's a good one. I'll tell you, you just put the click the location of the body part or whatever, and they'll tell you which sutures, and then if it needs to be taken out in 14 days, 7 days, etc. Another one is fractures. I put it out. That's another good one. Whether you need to call ortho or not, pretty much is what I use it for. Um, it'll same thing. You click the body part. Is it trimanular fracture? Okay, and then I'll totally call ortho. And then other ones are like, oh no, just outpatient follow up. So. But I will say that I think after 6 months, you're the first 6 months you're like looking to your attending like, please tell me what to do. And then after 6 months, you kind of are trying to get the hang of it, and you're like, I would not call ortho for this or whatever. And your attending is like, no, you gotta call ortho. And you're like, you call ortho. They're gonna yell at me if you wanna consult them. And so it's like kind of sometimes you realize, like, oh. I wouldn't have called them if it was me, but so it's just kind of getting a hang of those things. And then once you start your second year and your third year, I feel like there's a little more autonomy.
Yeah. I'm trying to look for this other app that I downloaded. Oh, this one. This is a really good one. Corpendium. This is
Okay.
yeah. I don't use it that much yet because I'm just so used to other ones. But when I have used it, these are what you're attending to use, Corpendium. They use that. A lot of you are attending to use Corpendium. So I can't tell you 1,000 things about it, but the two times I did use it, it was a few of these apps kind of like integrated in one app in their own
Oh,
way.
and sorry. Oh, there's another website. Y'all should have or started getting your NPI numbers now or starting to trickle that in. But Open Evidence is like ChatGTP, but for medicine, and it actually uses evidence-based like research papers and journals and stuff, where you just Google anything. Like sometimes there's so many times I want to Google something and I'm like, how do I even Google this? Open Evidence is great for that. It's free with an NPI number.
That's cool. I never heard of that. Wow, I'm looking into
It's
that.
for EM, it's okay, but more from like ICU rotations, it helped a crap ton.
Awesome. That was a lot of helpful information that you guys provided. I'm sure everyone is very thankful and grateful for that. So the next thing that we wanted to know, what type of procedures and clinical skills should we expect to master your first year of residency, as well as like, are there any videos that everyone should be watching just to help with mastery for those procedures and skills?
I will say if you want to prepare for anything, starting residency, like I wouldn't do much of the clinical stuff or the medical knowledge stuff, but I think it would be if you really want to, and then how a way to set yourself apart is getting good at procedures like central lines and A lines and LPs and stuff. Just watch some videos. Stuff that we really don't see a lot, like canthotomy, lateral canthotomies, things that you don't really, see a lot. And so if you just keep watching videos, hopefully, if that ever presents itself to me one day, I'll know how to do it. But I think that as far as again, this is program specific. Some programs get a little more procedures than others. Some places are set up differently. For my program, interns were the one intubating the first year, versus or they're running the codes. Interns are just doing airway. So I got my tubes, and then also I had my anesthesia rotation, like my third block. So I have like over 100 tubes by now. And that's definitely one that you're good at. That was the first thing that I got check marked. Yeah, usually central lines, um, A lines, peripheral IVs, ultrasounds. Those are all things that you can probably get check marked off by the end of your first year. I think that as far as mastery, like what you should focus on the most is doing peripheral ultrasound guided IVs. If you don't come across a lot of central lines, because I think it's it's a lot harder to do peripheral ultrasound guided peripheral IVs than it is to do ultrasound guided central lines. So if you're really good at getting it in the vein with it, then I think that will set you up for everything else when it comes to ultrasound, and then other procedures as well. So just really good at suturing, good at IVs that will help you set up for the other procedures that come your way throughout your 3 years of residency. And then I think if you really wanted to start learning stuff, I think watching procedure videos helps.
Is there any websites, like procedural websites, or anything that you guys recommend if we did
I just
watch
YouTube it.
YouTube? Okay.
YouTube. A lot of times I don't even know how to do this procedure. I haven't done it before. Even when I was a med student, and like again, this is where I got in trouble. Not like
Yeah.
I said
See one,
that
do one.
right. So like my C1 was YouTube. So some
Yeah.
who knows how to do a OG tube? I got it, doc. Never did it. I just went to YouTube and I was like, okay, looks like that's what I have to do. And I just prayed to God. Now, I'm not trying to tell you to do that. I feel like I
Oh,
have
yeah.
to be more confident in my abilities to do that, but that may also be my flaw in some ways. So,
I do good too. I would say like if someone asked me like, "Oh, have you done this?" Yeah, yeah, I totally have. Just
100%,
let me go like let me look YouTube it first.
100%. But then I go sneak off to my senior. I'm like, can you like show me how to like just tell me how I'm doing this real quick? And they're like, yeah, no doubt, no doubt. Also sidebar, the Kristen, the other moderator, I don't know your name. What's your name again?
Renata, you saw me a couple times last
Right.
month.
I'm flipping. I'm like,
Exactly. Yes, yeah.
this girl looks familiar. What?
Yes, yeah, that was me.
So, my apologies if I don't say a lot, right?
It's
Well,
okay. It's okay. It's
I,
okay.
this rotation that you've been with us, this I guess whatever I've been like, we had our mid-year reviews, and I just locked in really like to a different level since that. So
Yeah. Yeah. No, they
my
explained no. They explained how trauma service can be. So I don't have to
yeah.
explain it all. You're all good.
Well, I've been super locked in. Okay, now sidebar. Oh, back to the main bar. Whatever. I'm just throwing words together now. Um, so procedures, right? I love doing procedures, which is probably why a lot of you people are here. If you don't love procedures, is probably not the best area for you. I would say that. So get really ready. Now, some things you should be able to do. DREs, get your fingers in there, right? To the base of the knuckle, up here. And then you going to go around the lumen, right? You touch everything, right? If you see a patient and this patient says they have belly pain, right? 80%, it should be an 80% thought in your brain. It should be a thought in your brain that there's an 80% chance I'm gonna do a DRE in this patient. Right? Patient says they saw blood in their tissue. Patient said they see blood in their poop. Patient says that they have pain with their poop. You are putting your finger in their butt. That just is what it is. So in your brain, especially as a first year, you should say that because you're gonna go back to your attending, you're gonna report, and they're gonna say, did you inspect their rectum? And then you're gonna say, no, I didn't do that because one, you was like, oh, I don't want to do that. Get used to it. Matter of fact, you better do that, right? They'll be really impressed that you already came back telling them, this is what I saw. Okay. Pelvic exams, do them. Pelvic exams, do them. You better go back to your attending and said, hey, I already consented to do a pelvic exam. I just want to let you know I'm about to do that in the next 5 to 10 minutes. Do you have any other recommendations? Right? That is way more impressive than saying, I have 80 things as a differential. So get used to pelvic exams. Other procedures, and as Tamara said, all the ones that Tamara said as well, but I would say if there's a procedure that you are anticipating to do, it does not hurt you to take 5 minutes, 3 minutes to just look up that procedure real quick. Because a lot of your attendants are going to assume that you already looked up how to do this. Really good practice. Once you leave that room, you open up your app, whatever app is your favorite, and you put that thing in there and you say how to do this. So you're gonna walk in there and you're gonna tell them, this is what I want to do, this is how to do it. That's more impressive than the other thing. That had nothing to do with my intelligence. It had all to do with how you take initiative. So yeah.
That is great advice. Thank you, Dr. Daly. Now, you spoke briefly about mid evaluations, which kind of segues into our next question regarding feedback. How is, feedback, given to interns?
I think my program stands out because Dr. McLean, which is our associate program director, she actually gave a talk about evaluations and made an app. She wasn't like a computer engineer or software engineer in past life before med school, and then her husband's a software engineer, so she and her husband developed this app and stuff like that. So my program's really good about doing feedback. But as far as for us, we are required, but we're lucky if our attendings even do it. But getting shift cards a couple times a week is expected, and then it gets emailed to you. Then we have a DOTS evaluation. So this is kind of like where the attending comes and just watches you do like a start to finish patient. Like, they come with you in the beginning of the patient's room, and I think it's like twice a month that they want us to do it. And then they just see how you get the history, physical, and everything like that. And then they fill out an evaluation. I think there's one for nurses too. They evaluate you too and how your professionalism and stuff like that. And then every program has a mid-year evaluation where they kind of go over all your shift card evaluations are like pooled in one kind of numbers or something, and it's like, where are you supposed to be? And it's like a 1, 2, 3, 4, 5, and you're supposed to be at a level 1 by 6 months of your intern year, and then in 6 months into your second year, level 2, things like that. So there's lots of, I'm sure every program kind of has their own ways, but there's lots of different evaluations, and the more the better, because this all goes into when you graduate residency, and at least the first 5 years after residency, these places that you look for a job will send your program basically like a reference or something where they fill out everything and your kind of levels of competency in each category, professionalism, communication, all this stuff is included as well. So if you're a problematic residency, that will follow you out at least 5 years. So not just your knowledge base, but everything that makes you a person. So it's scary to think about, but setting yourself up starting into your year, I think, is key.
Yeah, that is great advice. 5 years out, that's crazy.
Yeah, even longer. My PD was saying that they've had people like jobs reach out to them like from residents that graduated like 10 years ago. So it's how you do his residencies will set you up for your career. And it's not just the clinical knowledge, it's just the whole like everything.
Can you repeat the question so I'm like answering it correctly?
The question was, how is feedback
Oh
and
yeah.
evaluations typically delivered to first year residents? The formal question.
Yeah. Program specific.
Yeah.
Typically get a mid-year review with everybody. So basically every 6 months you're gonna get a review, if I'm not mistaken. And your proficiency is tracked. And it's okay if you're not like as proficient in some areas. You know, some people are gonna grow exponentially, some people are gonna be steady, and some people are gonna just kind of like up plateau, up plateau, up plateau. So totally fine. Um, I would say that it's more about how you receive your feedback more than anything. So if you're somebody that's like, oh, that's not true, oh, I didn't do that, or because what's going to happen, they're going to pull evals, and you may have a shift that you had or multiple shifts with this one doctor who's a little bit more particular. They're going to be like, oh, you know, such and such doesn't know this, or they should be at a better level at this point in their in the year, or they may take your worst moment and put that in the evaluation. And then, and yeah, PD may ask you why, or they may not ask why, but you don't want to point fingers. You know, you want to have an explanation if it warrants, but all you're going to say is yes, sir, no, sir, I'm going to do better. I understand, you know, or I reflect on that situation, and these are the areas where I could have improved. And yeah, and that's going to make you look more of an astute resident than somebody who's just upset that they're not doing well. You're supposed to not be perfect right now, right? So again, ego check at the door.
Awesome. So always be open to constructive criticism and growth from that point on, pretty much.
And I will say that when I mentioned this kind of I forget it was this like evaluation form when you finish residency, it's not about moments in residency that, you know, maybe you're having a bad few months. It's about how you finish residency. It's like, is the impression when you finish good? Because there's like a few check boxes or something that like where does this person had any disciplinary action, or if they did have disciplinary action, was it resolved and stuff, and then you check that box. So it doesn't matter if you had disciplinary action, they're not going to know as long as it's resolved. So you know, you're going to have crappy moments, and you know, sometimes one year your intern year might suck, but then your second and third year, you know, you're a rock star. It's all about how you finish residency and not the little disciplinary moments or something that if you've had that. So you're allowed to trip and fall. It's okay. But it's how you get up and, you know, and face that adversity after that.
You have to crawl before you walk, pretty much.
Exactly.
Awesome. So for our next question, so we know the ED is fast-paced and high stakes. So we want to know how are first year residents supported by building their confidence and competency by their attendings and everyone around them.
So, go ahead.
No, that.
I was just gonna say, you know, I think it's same thing. Programs are specific. Every program is different in how they do mentorships and things like that, and how the avenues at which they have to, if you have any issues and stuff like that. And I think what makes a good program is having those avenues. You know, no programs first perfect, and every year is going to change depending on the needs of the residents. You know, one class might be totally different than the next class and the next class. So, and it's not a one size fits all. I think that finding your person, whether it's it's already given one to you. My program has a faculty mentor and a senior mentor, a third year mentor, and like a little mentorship, like mini groups that comprise of one intern, one second year, one third year, and then a faculty member. But it's not like, they're super strict on it. Like you can totally find your own faculty member or even co-resident or senior. Really find your kind of person or people to just kind of complain about too. I definitely, there's some moments that was a really shitty shift. And instead of complaining to my attending or nurses or something, I just waited and called my co-intern and we just vented to each other because, it's definitely okay to complain. You're going to a lot, but minimize who you complain to and find that person that you trust. Because EM is notorious for, for gossip. So
Yeah, and I would say um that you are responsible for you, right? First. Um, and then you build your team around you. You may have one already there, but you're all going to be strangers meeting each other to some degree. So you want to find, I have this thing that I've had for many years where I find three people. One person's a mentor, whether that's appointed to you or the one you choose, hopefully somebody you choose. Second is somebody who you learn from. And third is somebody you can teach, hopefully in that whole entire group, and everybody has a positive mentality. The moment somebody is like this negative Nancy, I kind of like, distance my way from that person or that group. So you have those three people or three couplets, you should be, set up for a good foundation. Um, and it's residency specific. Some residency programs don't do that stuff, and most should, but just because they have it on paper doesn't mean it's successful. So you're responsible for you. Please don't be that resident who, takes information, good or bad, and just like hermit crabs. You need to, first of all, you're all grown. We're all grown, right? And a lot of people who are in medicine, whether you like it or not, whether that's you or not, aren't super exposed to the world like the average person is. When I say that, I mean like a lot of people are bookworms. They don't. IMGs may be a little bit different, but that's just what it is. So I have this I have this internal issue where I feel like doctors go through life like they watch sitcoms and they speak in sarcasms all the time. Whether that's like, look at this guy or this mother, and it's nothing but sarcastic conversation. Whether that's because you're trauma bonding or it's whatever. How I grew up, that just was not how we spoke to each other. So I would say that know that this is a different environment, different players. So it's on you to really figure out like who that small group is, and everybody's not going to love each other, but you're all going to be professional with each other and rely on each other because EM is a team sport at the end of the day. You're not going to be the captain every day. So try to be the best role player you can be and find the best role players for your personal team.
Oh, I will say that as far as going back to the previous question of feedback and stuff like that, I am a very sensitive soul. Like I am super sensitive, hence why I am the biggest rule follower there is. I mean, now I kind of like bend the rules because the first 6 months I followed the rules to a T, and then nobody like batted an eye versus my co-interns, some of the ones that weren't really much rule followers, they just get picked on a lot more. And then now I bend the rules and nobody even like looks the other way, or they all like look the other way, no one says anything. But I do it all to avoid getting yelled at because I've had some bad moments in med school. But I will say, if you are like me and you're very sensitive to that type of criticism, find out now like what you can do to not beat you down. I think that's the most important thing, because I guarantee you, if someone yells at you, or your attending yells at you or pimps you, and someone, says something mean, I'm 100% there's people that have gotten it a lot worse, like have had things thrown at them, or like especially like surgery residents. I don't know. That's why I didn't want to do surgery, but I think that figuring out a way now to not let it take a heart, like take all the constructive pieces of it and throw all the negative BS stuff away from it. Figure out how to do that now. I think that will help you, because if it's not attendings, it's patients. Patients are mean. So, not all of them, but some can be. So I think figuring out that now, so that way, because it will just beat you down and bog you down and bog you down, and you'll never really have a moment to recover from it, because residency is very time consuming.
Yeah, definitely finding some coping mechanisms and learning how to kind of take things on the chin seems like will do us well going into this ER environment. That was our last question. I don't know if you guys have any other advice you want to add. If not, that's absolutely okay.
I would say that, like I said, enjoy now. Once I think getting close with the interns, if you guys can. I know some classes are not as social butterflies is not, but like, if you guys are all in the same city or something, meet up with some of your co-interns just to kind of get to know each other and build a strong bond. Because what I love about my intern class is that we are very close. We're very close, like codependent close. But it really helps make intern year smoother. So but really enjoy this time now. Like, it's not gonna be you wake up tomorrow and then you start residency. Things will, you have, like I said, you'll have things if you're out the weeks starting in June. So it will feel a lot easier to transition to it, rather than that really nervous like first day jitters.
Yeah, and to add to that, I have some like bullet points that I just wanted to like, you know, whether you keep these or not, you know, one, to be successful, right? Put your mind in this book, right? Whatever that book is. Um, because your job first year is to not say, dang, I don't see enough patients every day, or dang, and I'm doing all these procedures. Your job is to be proficient, right? And the only way you're going to be proficient is by knowing theoretically what to do, how to work somebody up, two, seeing it often as much as you can, three, not shying away from things. So there's some residents in our program who procedures come, they may not be as open to them, or they may be a little more shy, and there's some who just run to it, right? I would say run to it all, you know, because you want to mess up now before you are out in the field by yourself and don't know what to do, and mess up early, right? Next, as ER docs, I think the really important thing is knowing that your job is not only to there's three things that happen in the ED. People come in because they're in a lot of pain. People come in because they're about to die, or people come in because they're really scared. Or the fourth, which is like somebody who's disheveled, homeless, or whatever, they're looking for a place to stay. Those are the four main reasons why somebody's going to come there, right? So your job is to have the dispo in mind with every patient moving in. You're going to look, you're going to see, this is the chief complaint. Then you're going to go in the room and you're going to say, does this clinical picture match the chief complaint? And that's going to be vitals. That's going to be your assessment and such. And then you're going to anticipate all the wrong things that can happen based on what you see. Get your senses involved. What does it smell like? What does it look like? What do I hear? Right? Once you think like that, that helps with your assessment and plan, because that's the big shift from student to resident is what is going to possibly happen next, and what's my plan for that, right? And is this person staying? Is this person just treat and street? Or is this person patient somewhere in between, right? That in between is the meat and potatoes about you being a doctor. That's where you learn the most. Treat and street is easy. Somebody staying in the hospital, like, I mean, the most critical patient, you're going to do the same workup for many of the same critical patients. It's going to be broad, right? And when you order things broadly, sometimes it's just a reflex. And you're just looking at labs and, oh, this is probably the problem, right? But that in between is where you become a doctor, right? Lastly, you know, as I went into residency, I didn't realize that this is my practice. You own your practice, right? But before you have a preference in how you practice, right, you're going to see patients and you're going to, theoretically treat them, right, based on what the guidelines are. But then you're going to find different medicines that you are more familiar with, that you like better, right? And then you're going to form a practice based on this preference. But before you build your preference, be proficient. And then before you build your preference, become a master to whatever degree. And then you build your preference, right, after that. So please don't be that doc that says, yeah, oh no, I'm not going to order this image, series or study because this is not that. Wrong. That's ego. That is thinking that you know it all. No. Person's tender here, you order that study. The person, if you have an inkling of maybe, you order that study or you ask for assistance, right? Those are my big takeaways. ED is end in mind, anticipation on your brain, and don't be the hero. We're heroes in some sort of technical sense. Be a doctor and treat your patient, accordingly. So
Thank you so much to both of our panelists. That was amazing advice. I know we're all excited, but equally kind of scared to start residency. But I feel like we can just take these next kind of couple months, couple weeks really to just relax, get our attitudes right, and go in just ready to learn and absorb. So thank you all very much. Thank you to the participants for joining. This ends our webinar series. It will kick off next year again. So if you have anyone who's interested in emergency medicine, please let them know that AAEM runs a special series for IMGs. And yeah, thank you all. I hope to see you guys maybe in Seattle next year for AAEM's conference. That would be super fun. We will all put our information in the chat box. We're all here for each other. If you need anything, reach out. Again, thanks to our panelists and to my co-host, Renata.
Thank you guys. Have a good night and good luck on your first year.
And our phone numbers are in the chat.
Phone numbers are in the chat. Perfect.
Yeah.
Awesome.
Yeah.
Thank you
And I
guys.
just put in some quick tips there that I just thought of, but didn't want to spell out. But good luck. You guys are gonna do great. You already have the attitude of wanting to start off the year right, and that will go a long way. So good luck, you guys.
Thank you so much.
Thank
Good night,
you.
everyone.
Good night,
No worries.
everyone.